A very warm good evening to everyone from Tanzania. My name is Dr. Amar Swali. I am the consultant nephrologist and physician at Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania. And it is my utmost pleasure to introduce Dr. Sanjeev Arora, who is the founder and director of Project ECHO, Extension for Community Healthcare Outcomes, which is a globally recognized disruptive innovation that tackles the world's greatest challenges by providing access to knowledge and best practices in health, education, and other domains for rural and urban underserved populations. He is also the Regents and Distinguished Professor of Medicine with tenure in the Department of Internal Medicine at the University of New Mexico Health Sciences Center in Albuquerque, New Mexico. He's also served as the Executive Chair and Acting Chair of the Department of Internal Medicine and as the President of the Medical Staff. And he's also served on the board of the Health Sciences Center at the University of New Mexico. And he has also served as the president of the University Physicians Association. And this evening, Dr. Arora is going to be talking to us about the ECHO project, which is globally moving knowledge, not people. So we are really excited to hear more about this project, Dr. Arora. So I welcome you on behalf of the whole team.
Thank you. Thank you, Amar. It's such an honor and privilege to talk to all of you. And first of all, Happy New Year to all of you. I have been spending a lot of time in Africa recently. I was in South Africa, then I went to Ethiopia, and most recently I was in Kenya, and I saw the extreme need for expertise there. And I so want to congratulate you and also thank you for all the service you're providing to the people of Africa. And it's so delightful to see all of you today. So Project ECHO is something I started in 2003, but the roots of Project ECHO was laid down when in 2001, I saw a patient. I'm a gastroenterologist by profession. I'm a professor here in the US. And the patient was a 43-year-old woman, and she had two children in the room with her. There was a 14-year-old boy, a 9-year-old girl, and I asked her, how can I help you? And she said, I have hepatitis C and I want treatment. So I said, of course, I'll treat you. I'm a specialist in the area. And how long have you had it? And she said, I've had it for 8 years. I said, why did you not come earlier for treatment? Because we've had treatment for 8 years. And she said, I live 200 miles away from you. I called your nurse and there was an 8-month wait to see you. And she said I would have to make 12 trips while I was getting this treatment of interferon. As a nephrologist, obviously you understand hepatitis C. And the treatment was interferon and ribavirin in 2001. And she said, there was no specialist where I live in a rural area. And so your nurse said I would have to come 12 times, 200 miles each way. And I had a 1-year-old child at that time. And I don't have enough money that I could just take so much time off work and keep coming to see you 12 times. So I said, why did you come today? And she said, I'm having pain here in my right upper side of my abdomen. And I did an ultrasound of her abdomen, and she had a cancer of her liver, halfway between a golf ball and a tennis ball. And she passed away 6 months later. I was asking myself, why did she die from a disease where there was treatment available? And the answer was she died because the right knowledge didn't exist at the right place at the right time. And she didn't have the ability to get to the right knowledge at the right place at the right time. And this problem is not unique in the sense that all over the world, people are dying. Actually, the sad part of this story is that millions of people die every single year. So what is happening is that almost 1.6 million people die just from tuberculosis every year. And even though a treatment exists, similarly, about 1,800 children die every year just from diarrheal diseases. So they die every year from diarrheal diseases, even though oral rehydration and some simple antibiotics can take care of the problem. So our mission is to democratize the implementation of best practices for healthcare and education to underserved people all over the world. The idea is we want to save millions and millions of lives. That is the purpose of ECHO project. And it's not a project to disseminate knowledge like I'm doing today. It's a project to democratize implementation of knowledge. That means, how do we make sure people actually get better care? Our goal is to touch the lives of 1 billion people by 2025. But going back to 2003, to that patient, the challenge I was facing, she had of course passed away, but there were 28,000 patients living in New Mexico, all of who needed treatment for hepatitis C. And how should I treat them? I was working day and night, but the problem was I could not get to them because there were no specialists in rural areas. So I developed ECHO to treat hepatitis C and to monitor outcomes. And then I said, if I could do hepatitis C, I could do a lot of different things. The ECHO model is based on 4 key ideas. Use technology to leverage scarce resources, just like we are doing today. Sharing best practices. So I said I would democratize my expertise. So I went around the state of New Mexico, where I live in the US, Southwest US, and I told them, here's my protocol for treating hepatitis C. And they said, aha, this protocol is too complicated. We are not trained to give interferon. We can't do this. So I asked myself, how did you become an expert in treating hepatitis C? When I did my fellowship in gastroenterology in Boston, in Massachusetts, I would see a patient present to my professor. I would see another one present to my professor. And after 2 years, they started calling me a gastroenterologist. So I said, aha, I'm going to use this model of iterative guided practice to create new hepatitis C specialists in New Mexico by a case-based learning, all teach, all learn, and guided practice, and we would monitor outcomes. So I started the first ECHO clinic in 2003. This is what it looked like. This is very common now in Zoom, but in 2003, it wasn't so common. In the big box is the liver specialist, me, a psychiatrist, a pharmacist, and then all 21 would join on a Wednesday afternoon. So every Wednesday afternoon at 3 p.m., we started doing an ECHO clinic. And we would discuss 8 patients. 8 patients in a 2-hour session. And first, on the top right, Deb Newman would present a patient, then Liz Kuchler on the left would present a patient, and so on. Over 2 hours, we would discuss 8 patients, and I'd give them a lecture in treating. 15 minutes was a lecture on hepatitis C. And as I did this week after week after week, what happened was that they became experts. They became complete experts in the course of 1 year. And the wait in my clinic fell to 2 weeks. Over the next many years, we treated more than 10,000 patients. And the interesting part was, we started doing studies. As you heard from Amar, I'm a professor. We asked them, scale is 1, I have no skill in treating hepatitis C. 7, I'm an expert who can teach others. What is your ability to identify candidates for treatment? Went from 2.8 to 5.6 in 12 months. Can you treat hepatitis C and manage side effects? 2 to 5.2. Can you manage psychiatric comorbidities? 2.6 to 5.1. Can you now act as a local consultant in your local area? 2.4 to 5.6. Overall competence went from 2.8 to 5.5. But also we found that ECHO was producing joy of work for these rural doctors. It was diminishing their professional isolation, enhancing their professional satisfaction, and improving access to care. As I mentioned, 10,000 patients got treated. But really, the most important part of ECHO was we published an outcome study in the New England Journal of Medicine, which, as you're aware, is the leading medical journal in the world. We published that essentially these, I won't go over the data to you, but to say that rural primary care clinicians could deliver hepatitis C care with interferon ribavirin as safely and effectively as university, and that we can improve access to care for minorities. Once we showed this, it literally changed the world. I got up in the morning after the paper was published, it gets released at midnight, and I had emails from all over the world telling me they wanted to also use ECHO to improve care for underserved patients in their particular area. That means they wanted to help low-income people in their area to get better care using the ECHO model. So now we do ECHO for a lot of different diseases, for autism, for mental health disorders, for bone health disorders, cancer, cardiology, diabetes, geriatrics, hepatitis, HIV, addiction, psychiatry, LGBTQ health, palliative care, opioid use disorder, of course, COVID-19, pediatrics, rheumatology, etc., maternal child health. And the goal of ECHO is what we call force multiplier. You know, we need at least a 10 times expansion in nephrology expertise in Africa to help every patient, because the shortage of nephrologists is going to be so severe. That same is true for India. The same is true for all over the world. So with ECHO, what we have shown is that if we can make a nurse practitioner be as effective as a specialist or a primary care doctor, then you basically change the world in a big way, because now you've got 10 times capacity expansion. So in the US, we first demonstrated in a very important study that the risk of death from liver disease, 0.54 was the hazard ratio, was half. You could cut the mortality rate of liver disease by half if a primary care doctor participated in ECHO. In the US Department of Defense, we showed that opioid prescription patterns were dramatically different if primary care participated in ECHO. P-value was 0.004. We now have 500 peer-reviewed publications showing that ECHO is effective. These are coming from all over the world. 72 publications in leading journals show that patient health outcomes improve. 290 publications showing that doctors and nurses like to participate. It produces joy of work for them. 120 showing that their practice pattern improves. So the benefits of ECHO are improved quality safety, rapid learning and best practice dissemination, reducing variation in care, improving access for underserved patients, workforce training and force multiplier effects, improving professional satisfaction, integrating public health and treatment, preventing cost of untreated disease like dialysis. Since many of you are nephrologists, imagine if you could bring best practice care to people with stage 1 or 2 kidney disease, then, and slow the progress towards dialysis, how much suffering you could prevent. We want to democratize the expertise of, and why does ECHO work? Because it's an interactive learning environment. It's what we call low dose, high frequency learning. It's mentorship model. We co-manage patients. They learn by doing. They learn from our lectures. They learn from each other because they bring one patient to the network and learn on 8. But they learn through collaborative problem solving. This is where I live in New Mexico, in Albuquerque. We have close to 35 networks in New Mexico. We have taught currently 380 academic hubs in the United States. So every major university in the United States now does ECHO. And if any of you work in universities, if any of you work in public hospitals, if any of you work for the government in your country, and you want to become an ECHO hub, we will train you. We will give you our Zoom platform. We will give you our software, our iECHO platform, and you can start ECHO hubs in your area. And there's no cost for our collaboration with us. All the technical assistance we will give you will be free forever. So first we train University of Washington, then University of Chicago, then Boston, Massachusetts, then in Harvard University, Johns Hopkins, MD Anderson, Texas, and every other university, major university now has adopted ECHO. So what about what we are doing with you? We now have a global network. We have 850 hubs in the world doing ECHO. And you can see lots of ECHO hubs in Africa, and I'll tell you a lot more about it because this is the Africa Healthcare Network. And lots in India because I know Lloyd Vincent lives in India. So I have to tell him a little bit, show him a picture of that. But you can see how many ECHO hubs we have in Africa. We have 160 ECHO hubs. We have in India, 149 ECHO hubs, okay? Overall in ECHO, we have 4 million learners in 193 countries. So there are ECHO doctor and nurse practitioner learners in almost every country in the world, basically. And you can see the growth of ECHO over time. So this is where in what we're doing in New Mexico, in Africa, we have 700 organizations working with us. We've 500,000 healthcare clinicians in 54 countries in Africa have been mentored by ECHO. So I'll skip some of this. What are we doing in Africa? I would love to do kidney disease in Africa and in India, but currently we are not. COVID-19, vaccine, HIV, TB, hepatitis C, maternal infant well-being, pediatrics, mental health, lung cancer, cervical cancer, palliative care, etc. If you yourself are unable to do ECHO, please introduce me to other people in your governments who would be interested in launching ECHO for whatever disease area. And it doesn't have to be in healthcare. If we also have ECHOs in education, where the learners are not doctors, they're school teachers, because rural children are not getting a good education because there's no good teacher there. So if you want to do ECHO in your schools, we would also help you with that. And we partner with lots of, we launched ECHO in Africa in 2015. This is Namibia. And we partnered with the World Health Organization, Afro region. With them alone, we have trained 400,000 healthcare workers. This is again Namibia, our HIV ECHO there. This is our partnership with Africa CDC. It's a 40-country collaborative to implement international health regulations. This is partnership with the National AIDS Control Program in Kenya. And this is Kenyatta National Hospital doing ECHO. You can see they have trained 130,000 people all across Kenya and other countries. They've trained 20,000 nurses, doctors, pharmacists. They've launched a new ECHO for respectful maternal care with Kenya, Uganda, and Malawi. This is AMPATH out of Kenya, work in Western Kenya. I'll skip our work in cancer for right now, but we have a massive program in cancer, just to let you know. I'll skip that. This is our work in education, where we have networks to train school teachers. In Africa, we have a lot of work in maternal and child health. It's an area of huge importance for us because too many children, too many mothers die during childbirth in Africa. Too many children die at a young age. So we have maternal and child health programs in Africa, hubs in Nigeria, Kenya, Tanzania, Uganda, Ethiopia. So what do we do in maternal health? Drug and alcohol in the perinatal period, general perinatal health, high-risk pregnancy, etc. And I'm hoping the next time I give this talk, I'll be able to put in something for nephrology also. This is an example of how ECHO can help. This is Ethiopian Pediatric Society. So what they wanted to do is to delay the cord clamping. So after a newborn is born, we should wait for at least 60 seconds before we clamp the cord. So this was a quality improvement ECHO, by the way. But what they did is they partnered with 8 of the leading institutions in Africa. And if any of you is from Ethiopia, sorry, if any of you are from Ethiopia, you know St. Paul's and you know St. Peter's. So what happened is, what they found was only 27% of these hospitals were waiting for a minute to clamp the cord. If you clamp the cord too quickly after a child is born, the child is anemic, it's low birth weight, and it will over time be small in stature. It even affects their brain development because they become so anemic. You have to wait 60 seconds for the placenta to deliver all the blood and good important immunity to the baby. So they adopted ECHO, and in 9 months, the cord clamping rate across these 8 hospitals went to over 90%. Why am I showing you this slide? ECHO can be used to improve quality of care in dialysis centers through all teach, all learn, guided practice, case-based learning. We are very, very interested in helping in other sustainable development goals, quality education, good health and well-being. Our newest programs are in gender equality. And if any of you are interested in partnering with us on this, women in Africa have less access to dialysis. Women in Africa have less access to specialists because they can't travel as much. So we want to produce gender equity. This is also true for India. We also have projects in clean water and sanitation and others. I'm going to skip some of this now, and I just tell you a little bit that in addition, what will we bring to you if you partner with us? Okay, we will. So what we do is basically we train partners to launch new hubs. We help hubs work with their ministries of health to respond to priority needs. We want to test and expand education in Africa. We've already got a pilot in Nigeria now to mentor school teachers to be better teachers in math and science and literacy. We really want to work with you. So let's just say one of you wanted to do ECHO. How would we help you? That's the next slide I will show you. But the reason for starting an ECHO project is if you have a desire to serve your community, to give back to the world in return for everything you've received, ECHO could be a good way. This is a photograph of a physician. This is Albert Schweitzer. He worked in Africa and he said, I don't know what your destiny will be, but one thing I do know, the only ones among you will be really happy are those who have sought and found how to serve. I found this to be true in my life, that since I started ECHO, I'm a lot happier because I'm using my God-given resources to give back to the community. Why do we think we can reach 1 billion people? This is an important slide. This is Margaret Mead. They said, never doubt that a small group of thoughtful citizens can change the world. Indeed, it's the only thing that ever has. So I'm inviting you all today, if you have that interest, to partner with me on improving nephrology care for every citizen of Africa. We will give you all the support you need. I can assure you that you will not find us lacking. I have a team of 200 people in the US. I have a team of 180 people in Delhi. And I have 8 employees in Africa, in different countries. And this whole team will support you to launch your ECHO if you want to help your community with the ECHO model. So this is what I want to share with you. And if you have that interest, I will stop here and see if any of you have any further interest, okay? Over to you, Lloyd and Amar. Sorry, Amar, over to you.
Thank you so much, Dr. Sanjeev. First of all, let us say that all of us probably feel very, very inspired by the project that you had launched. The dynamic that existed back in the early 2000s and currently, where there weren't as many health professionals, or in all the countries, especially third world countries in Asia and Africa. People did not have access to care. Over time, we have seen some change with more specialists, more doctors graduating. However, still in the most remote areas, we would not have as much quality care as we need. And this is where your project shows that you have echoed to literally all corners of the world. And this is really fantastic to see the number of lives that you have changed over the years, and and that you're going to keep changing over the years. And congratulations for that.
Thank you, Amar. And the time is now to improve nephrology care. And so if one of your audience wants to launch an echo, what we will provide them is the following. They will sign a collaborative agreement with us. We will give them the Zoom platform for free. We will also give them access to this iEcho platform, which is basically will help them track all their activities. So to give you an idea of how that would work. So here is, for example, this is our iEcho platform. They were rolled out in India recently. So in 2022, 183 attendances, 48,000 unique learners. And you can see gender equity, 50% plus are females. This also tracks where these learners are coming from. You see India, Saudi Arabia, Ethiopia, etc. You see Sudan, etc. So it'll help you track that. It will also help you track who your learners are. So, for example, physicians were 8,800, nurses were 2,300. It'll also tell you what the specialty of the nurses is. So these are medical officers, these are TB officers, these are ophthalmologists, and so on and so forth. The other thing, for some of you who want to track outcomes, it'll help you do something very interesting. It'll help you track the effectiveness of your program. So this is the feedback dashboard. 10,000 responses, 4,000 unique responders, 57% of them are women. Look at the net promoter score. 69% are saying this is really helping them in their communities. It'll do pre-knowledge surveys, pre-session, post-session. See how their post-session knowledge improves, and it will allow you to publish from this. So this platform will also be given to you at no cost to you. So, and then you will get technical assistance from our team, 2.5 days training on launching Echo. So that's the value proposition I want to bring to you, because as you can tell from my voice, I'm really excited about the opportunity to meet you all in person, to collaborate with you, and we're having a Meta Echo Global Conference in the US from September 18th to 21st, where we'll have about 2,000 learners from all Echo doers and learners from all over the world. So if you want to come and visit us and see Echo and meet people from around the world, please come. And if you need a letter of invitation for your visas, we'll be happy to provide that. You just need to get in touch with me and I will assist that. Unfortunately, we don't have funding for that, but I'm very interested in collaborating with you. Over to you, Amar, for any Q&A. I think we've got 20 minutes left.
So as we speak, Dr. Sanjeev, we already have 2 queries of interest. One from Dr. Shija from Benjamin Kappa Hospital. He's a consultant nephrologist there. So we will connect him to you over email. And then we have another query again from Dr. Mutembe Kabuk. But as we keep commenting, I would invite other attendees to unmute and ask a few questions to Dr. Sanjeev, if any, or probably use the chat box to type your questions in, and we'll relay them to him.
And to the extent that you're willing to turn on your camera even for a minute for me to see you, I would love that. I would love to see your face and just connect with you.
There I am.
You can. Okay, good.
Yes.
All right.
Thank you. So Professor Bhima has his hand raised. So Professor Bhima.
Thanks, Amar. Hi, Amar. Dr. Arora, thank you very much for that very inspiring talk. I'm really, feel quite inspired by what you are saying. But of course, in developing countries, we face various challenges, and I'm sure you are very well aware of it, with cost constraints, constraints with staffing, etc. You said you had a hub at UKZN. Do you mind telling me who that hub is or where it is held? Because I'm from UKZN.
Oh, if you just email me, because we have we have 4,000 networks in the world.
Right,
I don't remember
right.
his name.
Okay. Now,
But
fine. I will email you.
There's somebody by the name of Srila Ramklas.
Yes, I know. She's the academic leader for teaching and learning. Okay.
Yeah, you can reach out to Srila Ramklas, but the real person who leads our work in UKZN is your dean. So when I was there, she's an African-American lady. She's a dermatologist.
Yeah, Dr. Nzoba. Yeah, she's the one.
If you could reach out to her, just write an email to her and tell her that I've asked you to connect with her, and she will see you right away and take care of it. She's the dean of the school there.
Yes.
Okay.
Yes. Fine.
And so
Thank you.
both of them, and if you meet with them, and then we'll take it from there and support you. Okay.
Sure. Thank you. Thanks, sir.
All right.
So while we wait for other comments and questions, Dr. Lloyd, we would love to hear from you.
I think it's a wonderful, a wonderful initiative that and has done so much across the board. Not only just medicine, but going into education and can be used for very many more purposes. In terms of nephrology, there are a number of people who are actually willing to put together a whole nephrology teaching session. So my question is, Professor Arora, how would these modules work now? So we will actually pick out topics and get sessions on board, which is recorded like in a video, or how do we actually go about it? Or it's be real time that we continue to do. And of course, I saw Dr. Prabhat in NIMHANS. It's an ongoing process. So we've got great programs going across India. The 46 centers are very, very active. What are the models of dissemination? That's something that I just wanted to know. That's all.
So I think that you will design your own project according to your needs. That's the first order of business. The curriculum, etc., are freely available through many sources. You can use any or create your own. But the real issue for you is whoever wants to do an echo. To decide which geography they want to work in. So, for example, Dr. Bhima probably wants to work in South Africa, right? Because especially in his state of KwaZulu-Natal, right? I mean, I think that the problem. So then, what happens is he will basically partner with us. We'll set him up, and then he's going to find, let's say, 30 or 40 primary care clinicians whom he's going to mentor to develop expertise in nephrology so that he puts together an effective triage system so that not every person just comes directly to him. Those people come to him that actually need his help, okay? And that's the key. And then other people, he could start a practice to prevent kidney disease. He could start a practice to help them manage proteinuria, etc. And then he'll give them talks. But ultimately, the idea will be to make these 40 primary care or others who want to learn, could be 100, experts in nephrology so that overall care improves. So that's the idea. But the design is dependent on your own need. So, for example, if the state of Bihar goes to sort of NIMHANS, says, we need help, then they help them with that. You see what I mean?
Yes.
Anybody else has a question?
Dr. Shija, then there is also Dr. Alfred from Dodoma, Dr. Shija from Dodoma. please unmute and talk.
So as
Dr.
we move,
Alfred?
Dr. Sanjeev, we have shared your email address on the chat, if that's okay. And anybody who would be interested in taking this further would probably reach out to you directly, if that's fine.
Yes, please reach out to me directly. And Professor Bhima, if you want to put your email address in chat, I'm going to connect you by email to the dean of your medical school. Okay?
It'd be really nice, we work together and form a sort of a nephrology group where we can actually discuss cases, on a regular basis. And this can be, and we can use, and through ECHO, across the board, we can do this. And this is a question of meeting up. And I've also contacted Dr. Santosh, who is very willing to help. Dr. Bhima can come in, Dr. Francis can come in, and we can form a full group here. And
Exactly,
across the board,
that'd be perfect.
Yeah.
Wonderful.
Yeah. So I think, so how do we connect now, Dr. Arora? How do we get all of us together on email and join in for a program? How do we go about that? Alfred, you can ask.
I think the first order of business is the Africa Healthcare Network will sign a collaborative agreement with us.
Yeah, sure.
That is signed.
Yeah.
Then you will go through a process of becoming an ECHO hub. Once you become a hub, you will be provided all the training to set up an ECHO. And okay?
Yeah, sure.
Yeah, thank you so much for this very nice talk, and actually I learned a lot about it. I don't have any comment, but I would just like to say thank you so much, Prof. Thanks.
So anybody interested in connecting, I would be happy to connect. Just send me an email or just a message on WhatsApp, and I will connect. Not a problem at all. Because they may be organized within your hospitals, like for example in Dodoma, Benjamin Kappa is the hub of Tanzania, Wimbili and places like that. I'm sure Dr. Jonathan, Dr. Shaw will be very happy to actually connect, and then because internally you'll have a lot of programs as well, so that can also work very well. And training across the board into various regional hospitals and things like that can also work. So we're very happy to connect, and just let me know. Just message me and I will connect.
Yeah.
No problem.
I think Alfred has a question. If we have time, I'll answer that. Yes, sure. You can offer exams and assess students. You can issue digital certificates. You can issue certification programs through ECHO. You can do all of the above in the sense that you can, yes, absolutely, literally achieve all those objectives of exams and surveys and so, for example, let's say Professor Bhima wants to issue a certification in pediatric nephrology to 20 primary care clinicians. What he would say is, okay, you can register for this certification program, and if you attend 25 separate times, and then you present 6 cases, and then take a written test at the end, we'll give you a certificate of completion in pediatric nephrology. So yes, you can do that. And Dr. Swali can do that in Tanzania if he wanted to, and Lloyd and Vincent in India. It's all of that is possible. You will be provided the entire technological framework that you need. And of course, if you would have to put in effort in it, but sometimes your government may be interested in partnering with you, because so many governments in Africa have already signed collaborative agreements with us. And so some of you may not know that. So perhaps I could just share the names of those people, so governments, because I think that way you could reach out to your own government and they can assist you in launching your ECHO, because so the governments that are currently in Africa who have signed collaborative agreements with us can be seen on this screen here. Okay, I hope you can see the screen. One is Cote d'Ivoire, Tanzania, Egypt, Ghana, Uganda, Sudan, Lesotho, Namibia, and Zambia. And we are also willing to support any other Ministry of Health that has an interest also. All right. Anything else, gentlemen?
No, that was great, Dr. Sanjeev, and it was very nice hosting you tonight for this talk. I would just hand over to Dr. Lloyd for one last comment before we sign off for the day.
No, thank you very much, Professor Arora. It was a wonderful session and so much being done, and I'm sure we're going to work together. And there are a couple of people a couple or more who are interested out here, and I will connect them as well. And so we can take it from there. So the Dodoma is the biggest hospital in the capital of Tanzania. Benjamin Kappa, that Dr. Shija is very interested. Dr. Alfred comes from the University of Dodoma, and and of course there are other people from Tanzania as well. So I will connect all of them as well. Thank you very, very much for this time.
Thank you so much. I'm really delighted to meet you. Bye-bye.